My name is Fesler. I'm going to be presenting this presentation on Morgellons Demystified. This presentation was put together by Marianne Middleveen, who couldn't be here today. She again is a veterinary microbiologist. Oh, and it popped back out again. Okay, so I'll just go ahead and get started. So Morgellons is a topic shrouded in mystery. New Scientist magazine referred to it as one of 7 medical mysteries yet to be solved. And it has been featured as a mystery on TV shows such as The Unexplained Files, Joe Rogan's Question Everything, Mystery Theater's Morgellons Disease, and the History Channel, Aliens, Plagues, and Epidemics. It has been attributed to chemtrails, nanite technology, alien experiments, extraterrestrial infections, government experiments gone wrong, and delusional disorder. In reality, Morgellons is not mysterious. There are explanations for this condition, and they are backed up by scientific research. Morgellons disease is a skin condition associated with spirochetal infection, primarily Borrelia species and other co-infections. It is characterized by spontaneously appearing, slow healing, ulcerative filamentous lesions that may be accompanied by stinging or crawling sensations. The key diagnostic criteria is the presence of colored filaments, mostly white, blue, or red, that protrude from or are embedded in skin. In this image, fibers are growing up from underneath the skin in a hair-like manner, so they cannot be textile fibers. There are many proposed etiologies for Morgellons. Some are fantasy, whimsical etiologies like extraterrestrial organisms, nanites, and chemtrails. The perpetuation of these etiologies on the internet makes it hard for Morgellons to be considered a legitimate disease. Some proposed etiologies are plausible theoretically, but there is no scientific evidence to support them. These are speculative etiologies, such as filamentous organisms like fungi or bacteria, such as actinomyces. They are not helpful in getting Morgellons recognized as a disease because they can be debunked, and they are distractions from studies that are supported by real evidence and published peer-reviewed studies. 2 key etiologies are proposed: delusional disorder and infection. The delusional hypothesis proposes that Morgellons is a mental illness, that lesions self-inflicted, that fibers are self-implanted textiles, and that patients have fixed delusional beliefs of parasite or fiber infestation. The infectious hypothesis proposes that Morgellons results from infection, that lesions form spontaneously, that the fibers are human biofibers, and that while neuropsychiatric symptoms can occur, these symptoms are secondary to infection. A quick PubMed search of Morgellons disease reveals that there are over 50 published papers supporting the delusional hypothesis. They are significantly flawed. Many are opinion papers with little or no research-based evidence. Around 2/3 are case studies. Many diagnose delusional mental illness contrary to the American Psychiatric Association's recommended practices. Many use inappropriate case definitions for Morgellons. Many use inadequate laboratory analysis, and none use methods appropriate to detect borreliosis. Of original research with bigger cohorts, there are 4 key studies and nothing published since 2012. One is a joint study by the CDC and Kaiser Permanente, and 3 are retrospective studies by the Mayo Clinic. All failed to perform lab analysis to detect spirochetal infection. All had flawed case definitions that did not include the presence of cutaneous fibers. And if done, fiber analysis was based on inappropriate methodology. In fact, the CDC study authors admitted the research themselves may have introduced cotton fibers during examination and collection. Nevertheless, they concluded the subjects were delusional. The first step in diagnosing delusional disorder is to determine if the belief in question is a delusion. Delusions are false beliefs, incorrect interpretations of external reality, are firmly held despite what most others believe to be true, and are maintained despite incontrovertible and obvious proof to the contrary, even to the point of being absurd. Delusions are not true observations, overvalued ideas, or mistaken beliefs. Furthermore, delusional disorder should not be diagnosed when there is an underlying medical condition such as an infection. If patients claim to have fibers on a lesion and they are physically present, then that is a true observation, not a delusion. If a patient has formication, sees a fruit fly land on his or her skin, then thinks the fly has relevance to his or her condition, then that is an overvalued idea. If a patient lacks scientific knowledge, sees fibers on a lesion, and mistakes the fibers for parasitic worms, then that is a mistaken belief. None of these beliefs are delusions. If a doctor cannot differentiate between a mistaken belief, overvalued belief, true observation, and a delusion, they have no business diagnosing delusional disorder. Skin must be visually examined to determine if belief in their presence is true or false. If a doctor refuses to objectively look at your skin, then he or she is not practicing good medicine. In contrast to the many studies claiming that Morgellons is delusional, there are very few studies that support the infectious point of view. 3 are reviews, 2 of which provide previously unpublished evidence. 7 are original research, and of those 6 involved larger cohorts, and there are 4 opinion papers. There are not many people who publish papers from the point of view that Morgellons is not delusional. We are sadly outnumbered. We hope that both patients and doctors objectively read and understand our evidence, and that eventually it becomes better accepted by the mainstream. In finding a possible etiologic agent for Morgellons, the common denominator appears to be various spirochete species from the genus Borrelia. 5 different labs have detected and identified Borrelia DNA from Morgellons skin and cultured specimens using PCR technology, confirming by sequencing. Australian Biologics, University of New Haven, Oklahoma State University, IGeneX Reference Laboratory, and Mount Allison University. Borrelia burgdorferi has been detected by all 5. Borrelia miyamotoi by Australian Biologics, B. hermsii by IGeneX, B. guerini by Australian Biologics and IGeneX. Using metagenomic sequencing, a 6th lab, Perkin-Elmer detected Borrelia burgdorferi from Morgellons skin specimens. Borrelia DNA was also detected in Morgellons skin by a 3rd method, fluorescent in situ hybridization, and this technique was performed by 2 labs, University of New Haven and McLean Laboratories in New York. Therefore, 7 have detected Borrelia DNA from Morgellons subjects using 3 different methodologies. This shows reproducibility and consistency. In addition to detecting Borrelia DNA, other methods have been used to detect Borrelia infection, including indirect methods such as serologic testing of patient sera and direct detecting Borrelia in patient samples, including skin from lesions and body fluids, such as blood, genital secretions, and urine. Methods for visual detection include light microscopy and electron microscopy. Light microscopic methods include detection of spirochetes in culture with dark field microscopy and the use of special staining methods such as immunostaining, which detects antigens, and Dieterle staining to see spirochetes both in situ, in skin samples, and in culture smears. Other pathogens have been detected and identified from Morgellons skin specimens by PCR technology, followed by sequencing. These include other spirochetes, Treponema denticola, detected by Australian Biologics and Oklahoma State University, Bartonella henselae, detected by Oklahoma State University and IGeneX Reference Laboratory. H. pylori, detected by the University of New Haven and Oklahoma State University. And Rickettsia species by Mount Allison University. Some of these pathogens, such as Rickettsia and Bartonella, are vector-borne, while others, such as H. pylori and Treponema denticola, are commonly found in humans. Other pathogens may be primary etiologic factors in some patients, co-contributing second etiologic factors, or maybe opportunistic exacerbating factors. Cutaneous fibers are the key diagnostic criteria for Morgellons. We have studied fiber origin and composition, and this has given us insight into plausible mechanisms. It is important to study only those filaments embedded in or firmly attached to skin, as seen here. Unattached fibers are most likely environmental contaminants. Some people have suggested that Morgellons fibers are filamentous or long, slender organisms such as fungi, filamentous bacteria, parasitic worms, or arthropod larvae causing myiasis. These organisms can cause disease in humans, and that could include Morgellons patients, but these organisms are not Morgellons fibers and are not directly involved in Morgellons pathology. Morgellons fibers are hair-like extrusions. They lack cellular structure, except at the base of the attachment with skin. Older cells in the fibers have lost cellular content, leaving the filamentous material. The fibers grow in a hair-like manner with a hollow center, or medulla, and solid exterior, or cortex. Cells divide at the base of attachment, and new cells push older cells outwards. Fibers are nucleated at the base of attachment, with skin and nuclei are continuous with those of surrounding skin cells, as seen on the top image. This shows they are produced by skin cells. Special staining called Gromori trichrome stain shows that the filaments are collagen and keratin. Keratin is staining red, and collagen is staining green. These are structural proteins. Collagen is produced by fibroblasts in the dermis, and keratin is produced by keratinocytes in the basal layer. Fontana-Mason staining showed that the blue coloration was actually caused by melanin pigmentation. Positive staining is black. The top left image is unstained. The bottom shows the fibers are clearly positive. The red fibers were negative, so red coloration remains a mystery. However, blue textile fibers colored by blue melanin does not exist, so these fibers cannot be textile. We thought filament composition might include an amyloid protein component, so we stained with Congo red. The staining resulted in apple green biopharyngeance under polarized light, suggesting possible amyloid protein content. This method is not specific, so we are investigating further. Fibers do not contain cellulose as found in plant materials such as cotton or chitin, such as found in insect or fungi. This was shown with calcifluoro white staining. Positive staining is blue-white. At the bottom, you can see that the sections of Morgellons fibers are darker than surrounding skin cells, so they are negative. Morgellons fibers are not fungal elements. They lack the morphological features and internal cell structures of fungi. They are not filamentous bacteria. They're too large and do not have morphological features of filamentous bacteria. Nor are they parasitic worms. They lack the morphological features and organs of these complex multicellular organisms. They are not arthropod infestation or a myiasis. Again, they lack morphological features of those organisms. Reproducibility is important in science. Dr. Matthew Shockey's group at the University of Akron independently confirmed the melanin content of blue fibers using microspectroscopy and electron microscopy. They reported the fibers had morphology consistent with human hairs. Transmission electron microscopy showed melanin, granulation, and melanocytes. They verified findings of keratin and melanin independently using different methods. Aside from cutaneous fibers, we are often asked to identify substances and artifacts found in Morgellons specimens. Morgellons lesions are sticky, and not everything that is on the skin has relevance. Many artifacts found in Morgellons skin specimens are environmental contaminants. Here are some environmental contaminants that have come from patients' supplied samples. Please know that we cannot identify all strange things that patients show us. We focus our attention on the most commonly found objects rather than objects unique to individuals. When determining etiologic factors, we look at factors that are consistently associated with the condition rather than a factor unique to an individual. And we do see patients bring in specimens that are vegetation or pollen and sometimes textile fibers or arthropods that have attached to lesions. We commonly see relevant objects that demonstrate defective keratization. Comedo-like keratinized plugs from within pores. They can feel like sand-like and unmagnified, may look like sand. These particles can have attached filaments, as seen on the bottom left, and all the images on the right. Filaments that form from within a pore can wind into a wad, as seen on the bottom right. Hyperkertotic follicular casts are common findings and indicative definitive keratinization. Some follicles produce downward growing hairs, as you can see in the top left. They can have unusual filamentous attachments, bottom and middle left of the slide. Filaments that form around sheath within a confined space can wind into a wad, as seen in the middle right image. They contain both keratin, stained red, and collagen stained green, as determined by Gromori trichrome staining as seen in the bottom right. Gel is frequently reported. We have fixed and sectioned gel, as we do know that it is full of Borrelia spirochetes, as seen in this immune stained specimen. All the red you see is Borrelia spirochetes. Gel is favorable environment for Borrelia. Hypothetically, it could be a human bioproduct, such as hyaluronic acid, or it could be a spirochetal byproduct. Dr. Avasapi's research has shown that Borrelia can produce alginate, so alginate is likely suspect. The presence of alginates is suggestive of biofilm formation. Feathers have been reported. Morgellons feathers are not the same as bird feathers. They are consistent with other Morgellons-related fibers, except they exhibit long branching. Bird down feathers have morphological features such as barbules that allow differentiation from Morgellons feathers. However, Morgellons and bird down feathers are not visually easy to differentiate. We do not focus on patient-supplied feathers because it is difficult to ascertain if they are environmental contaminants or Morgellons-related objects after they have detached. Specks are frequently reported. Examination reveals that they are a heterogeneous group of objects. They can be tightly wadded balls of dark Morgellons fibers, melanin-rich dermatological tissue, broken down bits of the follicular bulb, flecks of blood, or even environmental contaminating balls of dark textile fibers. We do not focus on them because when detached, it's difficult to ascertain if they're environmental contaminants or Morgellons related. Fuzzballs are frequently reported and collected. Early on, we did some testing to determine composition. Lack of uptake by Gromori trichrome stain indicated there were mostly man-made textile fibers. Textile fibers can tangle into Morgellons fibers or stick to extruding formed balls. They may contain some Morgellons fibers, but are mostly composed of environmental contaminants. They are not good specimens to study. Some Morgellons patients, but not all, report they have bugs in their skin. Arthropods are occasionally found in patients' collected Morgellons specimens. They include different types of arthropods, including both arachnids and insects, and also can include adults and larvae. The vast majority of these arthropods are not capable of causing infection. They accidentally adhere to wounds or could be opportunistic visitors. In our experience, fruit flies are the most frequently. Fruit flies do not cause infestation. Here are some more arthropods from Morgellons specimens. In all the hundreds of specimens we have looked at, only once did we see anything resembling an infestation. In that case, mites and mite eggs of an unidentified species were present in one specimen from one patient. It could be that this was opportunistic. Biological facts are important in determining if an arthropod has a role in a skin condition. Insects and spiders breathe through spiracles and can't live without a means to get air. It is impossible that a flying insect or hexapod such as Collembola could live enclosed under unbroken human skin as they would need to breathe. Practically every pest control operator has encountered a case of invisible bugs. The role of entomologists is to examine proffered specimens to determine if an arthropod is involved. What I did was talk to him, explaining the different biologies of known arthropods that can live on people, trying to get him to understand that what he was seeing is not biologically known to live on people. Trying to get him to understand that what he is seeing is not biologically known to science. These are quotes from two papers referenced. Entomologists are sought out by some Morgellons patients to examine specimens. Mostly entomologists see that there are no arthropods capable of infestation. They then conclude that Morgellons is a delusional disorder. Reports and interviews by entomologists are then used by doctors to support the delusions of parasitosis hypothesis. Please think very carefully before presenting specimens to a doctor, entomologist, parasitologist, or other experts. Hexagonal crystals and glitter are reported by some Morgellons subjects. We have studied these specimens. All the hexagonal crystals we have analyzed are synthetic man-made glitter, consistent with glitter on a card and craft materials. The smaller glitter particles that we analyzed were identified as salts. These were human bioproducts, but possibly other sparkly particles on the skin from cosmetics or lotion. Showing self-collected specimens to a doctor is called the matchbox sign and can be used to justify a delusion of parasitosis diagnosis. Cutaneous Morgellons fibers may be misidentified as self-implanted textile fibers. Self-collected specimens may contain contaminating artifacts unrelated to the condition. These include arthropod, bits of vegetation, and synthetic particles. Strange artifacts that look like parasites but are not parasites can be found in Morgellons patients' collected specimens. Microscopic non-living fibers can move by electrostatic or mechanical energy but are not alive. Many people with Morgellons think non-living fibers are living because they move. We have seen many videos, but we have not seen any videos of movement consistent with that of a living modal organism. Bottom line, be careful what you take to your doctor. If you're going to show your doctor specimens, it might be better to show them cutaneous fibers in situ or on your skin rather than self-collected specimens. However, if you do choose to show your doctor cutaneous fibers, be aware that he or she may refuse to look or may diagnose the fibers as self-implanted textiles, and then they may diagnose delusional disorder. Proving a causal relationship between an etiologic agent and an illness is more likely if there is an analogous animal model. An analogous filamentous condition has been reported in canine model. Dogs in this study had blue, red, and white filaments composed of collagen and had defects in keratinization, such as deformed hairs and thickened follicular casts. They too had detected Borrelia infection. We also know that cattle can get a similar condition called digital dermatitis. Comparison to this disease gave us clues about Morgellons disease. The lesions have unusual filamentous projections that are composed of keratin, and spirochetes are visible in the tissue. In the case of digital dermatitis, the spirochetes are treponemes. They're not the same species of spirochetes as those associated with Morgellons, but they are genetically related. Experimental infection with pure cultured spirochetes reproduced the condition in calves, showing a definitive causal relationship. Therefore, we know that spirochetes are capable of inducing a condition similar to Morgellons and that it is caused by keratin proliferation. As far as mechanism is concerned, it is well-established fact that infections can cause abnormal keratin expression and keratin proliferation. Epstein-Barr virus, or EBV virus, causes a condition called hairy leukoplakia in HIV patients. White hair-like keratin growths occur in the mouth, mostly along the tongue. Cholesteatoma is a condition in which an inflammatory process due to infection with various bacteria filamentous results in keratin growth inside the ear canal, as you can see in the lower right. Borrelia can invade both keratinocytes and fibroblasts, the cells responsible for producing keratin and collagen. Intracellular sequestration contributes to antibiotic resistance and immune evasion. The study by Arbour et al. Shows that co-culturing fibroblasts with Borrelia induced upregulation of collagen and growth factor mRNA. Borreliosis enhances collagen expression and stimulates growth factors responsible for increased collagen production. Most Morgellons fibers are composed of collagen. As you can see in the image of Morgellons fibers positively stained for collagen. An upregulation of keratin and collagen is possible in Morgellons pathology. The take-home message of this talk is that it is better to focus on the underlying infection or infections that contribute to Morgellons rather than focusing on all the strange objects found on the skin or in the surrounding environment. Diagnosing and treating underlying infections is essential for improving the skin condition. This is the leg of a Morgellons subject before and after 3 years of treatment with antibiotics. It is possible to get well. And then Marianne would like to thank Cindy Casey and all the Charles E. Holman Morgellons Disease Foundation. Thanks to her co-authors, Dr. Jenny Burke, Melissa Fesler, Peter Main, Ava Sapi, Joshna Shaw, and Raphael Stricker. Also thanks to Dr. Vet Lloyd and Julie Lewis at Mount Allison University for collaboration and helpful discussion. Thanks to Drs. Virginia Savely and Randy Winemore for their pioneering work on this disorder. Thanks to all the Morgellons patients who generously provided samples and shared their knowledge of Morgellons disease. Lastly, thank you for your attention. And here are her references.